towards the end of your talk, if it's okay, we can just go through, all of them.
Okay, sounds good.
And then, let's see. Oh, awesome. All right. So thank you, Dr. Cates, for being with us. We have a special person that would like to introduce you, if that's okay.
Good morning, everybody, and welcome back to New York, Max. It's I know it's a virtual visit, but we really appreciate you taking the time out, and it's really my honor and pleasure to introduce Max Cates, who, although not officially alumni of our institution, did spend a year doing clinical research with us. And Max, along with multiple other alumni from our place, have made the decision to move down to Baltimore and join Johns Hopkins. And it's really been New York's loss and Baltimore's gain. But I'll say, out of all the alumni that have left Columbia to go to Hopkins, Max is the only one that's intelligent enough to pursue an academic career in bladder cancer. So that makes him very specifically unique and somebody that I'm even more proud of. So he's a master of both non-muscle invasive and muscle invasive bladder cancer, is a rapidly rising star in our field. And I really look forward to hearing his thoughts on muscle invasive bladder cancer. Welcome, Max.
Thank you so much. We just finished, Jews just finished Passover, and we always say at the end, next year in Jerusalem, and maybe it'll be next year in New York.
There you go.
All right, so I have no disclosures relevant to this talk, other than to tell you, the Empire Urology Series is a New York series. I viewed Mount Sinai and Columbia as two homes, and so I feel very blessed to be able to speak to all of you. But it really this week should be called the Evidence of Multiple Esteemed People Interested in Bladder Cancer Resident Education, because this week you guys had and have an amazing group of bladder cancer experts talking to you. And so when I looked at your curriculum, I decided it would make most sense to try to speak around what you're already learning. So what I'm going to cover are some basics of clinical muscle invasive bladder cancer, spending particular emphasis on core curriculum, guidelines, and randomized controlled trials. I'm specifically not going to be talking about urinary diversion, because you're going to be hearing about that tomorrow with Dr. Bachner. And I'll also leave out advanced disease or metastatic disease, because you're going to be hearing about that from Dr. Sternberg. So this was the old paradigm, essentially. If you had non-muscle invasive disease, you saw a urologist who would give you BCG and possibly remove your bladder. If you had a muscle invasive disease, you'd see a urologist, get your bladder out. And if you had metastatic disease, you'd go see a medical oncologist. But now we're in an era of where it's not so simple. My wife saw this slide and said, "You can't show them this slide. It's too confusing." The reality is it can be, and this is why bladder cancer today is a multidisciplinary field. I see 80% of my patients, and some of them are non-muscle invasive, muscle invasive, and metastatic disease. I see them with Dr. Hahn, Noah Hahn, or Jeannie Hoffman-Sensis, the medical oncologist who focuses on bladder cancer. The reason being is that we're giving systemic therapies for non-muscle invasive disease. We're doing local therapies for metastatic disease, and it's really a all hands on deck approach. And the radiation oncologist is increasingly involved in how we manage this disease as well. So as you all know, bladder cancer is extremely common. Looking at the statistic, seventh most globally, most common, number 4 most common cancer among men in the United States. What's interesting to me, though, is that its rate, and you can see here, I hope you can see the arrow, but the rate has been relatively constant as other cancers have decreased. Lung cancer in particular, attributable to smoking, has been decreasing, and bladder cancer, of which 30 to 40% are attributable to smoking, has not changed at all. And so this speaks to the amount that basically I interpret this as what still needs to be done in order to start decreasing this curve. What are the origins of bladder cancer staging? This is one of my favorite papers, 1946, Hugh Jewett George Strong published an autopsy series of 118 cases. And basically what they did is they took patients who had died of bladder cancer and said, how many of those patients have lymph node involvement? How many of those patients have concomitant metastases? And from that, they calculated what is the curability of this patient. And what that allowed them to do is group patients into staging. And this is the old Jewett staging that then got updated and updated and updated until you get to our modern staging system, which is actually very similar. And it's important to think when we think about staging, staging is really trying to assess prognosis. So does it really matter if the cancer cell is invading into the muscle? What does that say about the prognosis? And that's what the Jewett staging originally did. And so as we can see, the reason why we think about bladder cancer as being so different from non-muscle invasive to muscle invasive is really about the 5-year stage specific survival, which goes from 98% with early stage disease to 88% with invasive disease to 63% with muscle invasive disease, and actually 46% with T3 and T4 and on. What's interesting to me is that there are major drop-offs, not just non-muscle invasive to muscle invasive. It's just that we have some difficulties figuring out some of these other things. For example, the difference between stage 2 and stage 3, or T2 and T3A, is incredibly difficult clinically. An MRI is still not good enough. CT scans certainly are not good enough. So to make that clinical differentiation is challenging, but the 5-year survival does go down as well. So this is important to keep in mind. So I'm going to be focusing most of this talk, kind of scaffolding it around the 2017 guidelines. And let's just jump right in with the role of neoadjuvant and adjuvant therapy. So the guidelines state that clinicians should offer cisplatin-based neoadjuvant chemotherapy to eligible radical cystectomy cancer patients, and that's a strong recommendation. And similarly, if they are not eligible for platinum, either because they have poor kidney function, hearing loss, neuropathies, there are many reasons why a patient should not get platinum. Those patients should not get carboplatin-based neoadjuvant chemotherapy, and that is in the guidelines. Additionally, patients who are not offered cisplatin-based chemotherapy, and this is statement 9, and have non-organ confined disease, so node positive or T3 or T4 disease, those patients should be offered adjuvant chemotherapy. And this comes up quite a bit. Patients can't get neoadjuvant chemotherapy for many different reasons. They're symptomatic, they're bleeding, just to name 2. And then their bladder comes out and they have advanced disease. Those patients should be offered chemotherapy. Where does this statement about neoadjuvant chemotherapy come from? So at the end of this talk, there's going to be about probably 6 to 10 articles with hyperlinks, and those will be available to you with kind of what I consider the most important papers that if you're not going into oncology, you're not going into bladder cancer, you should still be familiar with. This is one of them, and I'll also put those on Twitter as well. So this is the Grossman trial, New England Journal, 2003, and patients were randomized to cystectomy versus MVAC. With cystectomy, they were stratified based on age and clinical tumor stage. Very interesting, the age that they were stratified on is 65. For those of you that take care of bladder cancer patients, you'll probably recognize that 65 is the lowest quartile of patients. The average age of our patients are 75. So that probably overstates the younger population a little bit. But regardless, they were stratified on age and tumor stage. And essentially, there's many different ways to interpret this trial. So I'm going to interpret it in the way I choose to, but you will hear different people interpret it differently. And I'm just moving my Zoom thing around so I can access everything. But the way I interpret it is that the median survival at a medium follow-up of over 8 years is 77 months versus 46 months. There was a difference of 10 deaths, so 90 deaths in the MVAC with cystectomy arm, the neoadjuvant chemo arm, versus 100 deaths in the cystectomy arm. So people will spin that as an absolute value, an absolute difference, which actually sounds less. It's in the single digits. But when you actually break it down to what is the difference in median survival, it's 77 months versus 46 months. And furthermore, when you look at this median survival difference stratified by age and clinical stage, it holds true and is significant. So it doesn't matter if patients are older than 65 or younger than 65, there's a clear and significant difference in median survival. It also does not matter if they're T2 or T3, T4A. You know, you'll hear arguments that neoadjuvant chemo should be reserved just for T3 or T4A. But if you actually look at the data, you'll see that the median survival difference in terms of months is significantly different no matter how you stratify the data. So I interpret this as clear and definitive support for neoadjuvant chemotherapy. Additionally, not surprisingly, moving this over. I'm not a Zoom professional, so I'm constantly moving my the windows over so I can see the slide. More patients in the neoadjuvant chemo arm were PT0 compared to the cystectomy alone arm. So what that essentially means is that neoadjuvant chemo tracks with survival. It's associated with improved survival, but it's also associated with improved complete response. So at the time of cystectomy, there's no cancer in the bladder. And the rate of that in the neoadjuvant chemotherapy arm was 38% versus 15% in the cystectomy alone arm. And this brings up an important point, which is that 15% in which the bladder was removed and there was no cancer there and the patients did not get chemo, that essentially means that the TURBT alone cured their disease. That is the way I interpret that. And that was 15% of the time. And this brings up an important point, which is no matter the treatment paradigm, a high quality TURBT is the most important aspect of any bladder cancer management strategy. So when I have a patient who's referred in, and this is the most common referral I have, with a pre-existing diagnosis of muscle invasive bladder cancer, I do my very best to take them to the operating room for a repeat TURBT before they go on to chemo. The reason being, if they're going to be a responder to chemo, then great. But if they have a bladder cancer biology that makes them resistant to receiving chemo, that is not going to address, the chemo is not going to address that cancer, and they're going to have a lot of residual disease, then I could potentially cure them of that chemo-resistant tumor just with my TURBT before I send them to chemo, and I won't have wasted 3 or 4 months. So that's why I try to take as many patients as possible to the operating room for a complete radical, however you want to call it, TURBT before they are getting neoadjuvant chemotherapy. And so we also looked at this in our group, and basically this was a retrospective study where we wanted to try to figure out, well, what percent of chemo response is just from the TURBT. So what we did is we took a historic sample of patients who had gotten neoadjuvant chemo. We took a similar group of patients that had gotten no neoadjuvant chemotherapy, just the cystectomy. And we looked at the PT0 rate, and we also looked at partial response rate. So that's including T1 and non-invasive disease. And what we essentially found, and I won't get into the methods, but that around in a multivariate logistic regression model, 40% of therapeutic response could be attributed to TURBT. This is Dr. Herr's data, which essentially shows that there are patients out there, and quite a few, that are and can be managed with TURBT alone. And I'm not advocating this, but I'm basically using this as another way to say that the TURBT is an essential component of the muscle invasive bladder cancer management strategy. So this is a thought-provoking paper that I enjoyed from the group at Columbia. And it says, okay, so if I just showed you data that the TURBT, that neoadjuvant chemo tracks closely to progression-free survival and to overall survival and to CR, meaning complete response, why do we need to remove the bladder after a complete response? And in fact, in this study, which was a combination of Memorial Sloan Kettering and Columbia, they did not. So patients who had a clinical complete response after neoadjuvant chemo were monitored with surveillance. And essentially what they showed, and many of the people are on this Zoom, I see their faces, but essentially what they showed is that in a highly select group of people from 2 institutions that are very comfortable managing these types of patients in this way, 5-year disease-specific survival was 90%, and patients could be, in 5 years, cystectomy-free survival, which I think is a really important metric, was 76%. Around this same time, or sort of what's also been going on, is that there's been, and this talk is primarily clinical focused, but we can't ignore what's going on in bladder cancer biology, is DNA damage repair mutations have been shown to predict response to neoadjuvant chemotherapy. In this study by Dr. Plimak from Fox Chase, she looked at ATM, RB1, and FANCC, and also ERCC2 has also been implicated in this. But these genomic alterations have been shown to be associated with response to neoadjuvant chemotherapy. And so based on that is the schema for a couple trials. This is one of the trials, which is patients undergo a TURBT. They're then sequenced, and if they have, and this is one that is out of Fox Chase, but we have open at Hopkins. If they have one of 4 genomic mutations, and if they are a complete responder to chemotherapy, they're managed with surveillance. And if they relapse with muscle invasive cancer, they go on to definitive therapy. If they relapse with a non-muscle invasive cancer, then it's a little bit complicated. It's the physician's choice with the patient, but it's all protocolized. And I think this is a thoughtful way to do it. However, also something to keep in mind is there are a lot of problems with the way we stage after neoadjuvant chemo. This is a study out of our institution that essentially shows that in up to 50% or approaching 50% of patients that we think are CT0 or complete responders to chemo, we're wrong. So we think they're CT0, we remove the bladder anyway, because that's standard of care. And we're surprised to find that up to half still have evidence of disease, and more than 20%, 22% have residual muscle invasive bladder cancer. So this is food for thought as we generate paradigms that are sort of outside of our guidelines and outside of our standard of care that are trying to push the field forward. We need to do this thoughtfully, and I think we are. But this is a major issue as we think about how to preserve bladders. So in addition to neoadjuvant chemotherapy, many are looking at neoadjuvant immunotherapy. This is a phase 2 trial out of Europe The Pure one study that looked at neoadjuvant pembrolizumab was published in Journal of Clinical Oncology within the last 2 years. And what they did is they gave 3 weekly cycles of pembrolizumab before cystectomy, then did cystectomy and assessed pathologic CR, as well as a host of translational components of the study. And basically what they found is that the pathologic complete response rate, which was their primary endpoint, was 42% in all comers. And this was a small study, 50 patients. But in patients who, CR was highly associated with PD-L1 antibody staining on.
Gotta look out for.
I think that some people have their mute off. If you could just put your mute on. Was highly associated with PD-L1 antibody staining. And so this has informed other trials that are similarly trying to approach patients who are not candidates for neoadjuvant platinum-based chemotherapy to try to give them other neoadjuvant therapies prior to cystectomy. So let's move on. What do the guidelines say about principles of cystectomy? When performing a standard radical cystectomy, clinicians should remove the bladder, prostate, and seminal vesicles in males, and should remove the bladder, uterus, fallopian tubes, ovaries, and anterior vaginal wall in females. And so I'm gonna challenge that a little bit in the next slide. Let's just keep going. Clinicians should discuss and consider sexual function preserving procedures for patients with organ-confined disease and absence of bladder, neck, urethra, and prostate. So 30 years ago, this is the way a review article about radical cystectomy in a female patient looked. And this is not a criticism of these authors, but this was just how it was thought of. Radical cystectomy and in parentheses, anterior exoneration. I can tell you, I do not view those two things as the same operation. And I think increasingly, most people who are treating bladder cancer appreciate that the ovaries do not need to always be removed, and in fact, usually do not, that the uterus and vagina often can be spared. And there's a lot of movement to be more thoughtful about this. And the context is that, you know, in prostate cancer, I think we're so well trained to discuss sexual function with all our patients. I mean, if you don't have a shim on a new prostate cancer patient as a resident, something's the matter. Like, you've done something wrong. And yet in bladder cancer, we're less trained to discuss sexual function with our patients. And this is a survey done by Natasha Gupta from our group that essentially looked at academic urologists and what % are discussing sexual function with their patients. And the vast majority are not discussing sexual function with male or female patients. And I would say that this is even more true among female patients, that physicians are just not comfortable speaking to them about sexual function. And that's incredibly important. If the patient has a muscle invasive tumor, there's no suspicion for invasion into the uterus. There's no suspicion for invasion into the vagina. MRIs are actually pretty good at delineating that nowadays, as well as an examination under anesthesia. They're sexually active and want to preserve their sexual activity. I mean, that is not an uncommon patient, and I think that there's a lot of reasons for it. We're biased, as this study showed, towards patients being older age, and as we know, that should not impact the way we discuss this with them. But I hope this is changing. But moving on, let's discuss more principles of radical cystectomy. So here there is going to be good evidence to discuss perioperative pharmacologic thromboembolic prophylaxis should be given. And then in patients undergoing radical cystectomy, a mu opioid antagonist should be used to accelerate gastrointestinal recovery. So these are in the 2017 guidelines, and they're highly testable. And what is this really discussing? This is discussing ERAS, or the concept of early recovery. And this is coming out of the GI literature and the colorectal literature in particular. And essentially the problem is that GI complications are, as all of you know, very common after a cystectomy and a urinary diversion. 20 to 40% of these patients are getting ileus within 90 days. And so this caused ERAS protocols to be developed. And one early thought as all of these protocols were being developed was, well, will minimally invasive approaches not also reduce GI-related toxicity? So I'm going to just use this discussion around ERAS, which is sort of in the guidelines, to discuss a concept that's not in the guidelines, but I think should be given a little bit of time on the microphone. And that's the concept of minimally invasive cystectomy. The reason it should be given some time is that we do have a randomized controlled trial, a phase 3 randomized controlled trial, comparing robot-assisted and open radical cystectomy. And I should note that the main objective of this trial was not to show a difference in GI-related toxicities after cystectomy. I'm just using it in this talk as a way to talk about this. The main objective was to show non-inferiority of a cancer outcome, which was in this case a 2-year progression-free survival, to essentially show that there is no difference in 2-year progression-free survival, which we all know tracks pretty closely to cancer-specific survival between robotic and open radical cystectomy. So in this study, 350 patients were enrolled and randomized and assigned to an open cystectomy or a robotic cystectomy with an extracorporeal urinary diversion. They were stratified on the urinary diversion type and the T stage and their ECOG status. The primary outcome, as I said, was 2-year progression-free survival. And essentially what was shown is that 2-year progression-free survival was around 72% in both arms. The p-value is a little confusing. The p-value shows that it is significant for non-inferiority. So that it's significantly showing you that there's no difference. So be careful how you read some of these studies when you have to look at the actual study design. This is what's interesting to me is the 90-day complication rate, and just look at all. I added this into their data, but look at all comers. The 90-day complication rate was 69% in the open arm and 67% in the robotic arm. I mean, 2/3 of patients had a reportable complication, and 22% in both arms had a Clavian 3 through 5 complication. And so this is randomized data of a surgery we do all the time, showing us what we already know, which is that it's associated with significant morbidity. I also want to highlight that the rate of ileus, which brought us to this trial, was no different in either arm and was around 20% in both arms. And we could spend a whole talk talking about this subject, but we won't today. So let's move on to discussing the concept of ERAS, which is essentially a preoperative strategy, an intraoperative strategy, and a postoperative strategy to, number 1, decrease fluids, number 2, decrease opioid analgesics, and number 3, use mu receptor antagonist as a promotility agent, and many, many other things. But I'm trying to pare it down. This is an abbreviated version of our program at Hopkins, and essentially it does what I just said. We have every place has their nuances, but the concept of minimizing fluids, which minimizes edema to the bowel, minimizing opioids, analgesia, which, as we know, it slows down the bowels, and then using promotility agents are the fundamentals. And what's the data that supports this being in our guidelines? Okay, that's the question we should be asking for all of this, is when we should be focusing on what's the data that supports this. So this was a randomized controlled trial supporting Alvimopam use for radical cystectomy. And in this study by Dr. Lee and colleagues, published in 2014, patients were randomized to Alvimopam and placebo. So it's one of the few placebo-controlled surgical trials. It's not really surgical, but it's perioperative in our field. And patients, let's just jump ahead and look at the differences. So what it found, and by the way, this is a trial that can be used to justify Alvimopam use at your hospital and at many hospitals. It's an incredibly expensive drug, and there's a lot of resistance to using it in some institutions. And this is why this trial is so important, because we actually have data that can support its use in our field. So what did it show? It basically showed, if you look at the median difference in length of stay, patients who were using Alvimopam at an average length of stay of 7 days versus placebo, which was 8 days, which doesn't sound too impressive. But when you actually think about, well, what's important in a cystectomy, I think most residents, most surgeons who do these cases understand that if a patient's in the hospital longer than a week, something is probably going on. Yeah, there's occasionally it's frailty and it's some issues around rehabilitation, but something is probably going on if they're there sort of longer than a week. And that's why I like this statistic, which shows us what was the prolonged length of stay past a week. And we can see that the Alvimopam group was 33% versus placebo group, which was 52%, 51.5%. And obviously then the ileus-related morbidity was 8% versus 29%, probably driving a lot of these outcomes. So this informs why why a mu receptor antagonist, why Alvimopam is in our guidelines, and then how ERAS is taken off of that. So let's keep moving. Let's move on to lymph node dissection. So in the guidelines, clinicians must perform a bilateral pelvic lymphadenectomy. And when performing this lymph node dissection, they should remove at minimum external and internal iliac and obturator lymph nodes. And that's all that's said. So that brings up a lot of very interesting controversies. Okay, well, what should the lymph node dissection be? That seems pretty limited to me, but why is there not more in the guidelines? So the answer is going to be because there's not good enough data. So let's talk about what data there had been, and now what data is coming. So when we talk about a lymph node dissection, it gets very confusing very quickly, because as you review the literature, what you'll realize is people have different definitions of lymph node dissections. So for the purposes of this talk, I'll try to stick to the following nomenclature, which is basically a limited pelvic lymph node dissection. It would be the external iliac artery and vein, and the obturator lymph node packet. A standard lymph node dissection would also include the internal artery and the deep obturator nodes. An extended node dissection would include the presacral nodes and the nodes above the iliac bifurcation to the level of the aortic bifurcation. And the super extended would include everything I just said, but the nodes lateral to the external iliac artery, and then up to all the way up to the IMA. So if you look at the historic studies, population level data seems to support a very small but clinically significant improvement in cancer-specific survival and overall survival with a lymph node dissection. This is just with any all-comers lymph node dissection, no lymph node dissection. And if you look at the historic USC data, which is some of the best data we have on this subject, what you'll find is that patients who have positive lymph nodes obviously do much worse than patients who have negative lymph nodes, 244 patients versus 810 patients in this study. But also the more positive lymph nodes that are removed, usually the worse they do. And specifically, once you get greater than 10 lymph nodes, the mean recurrence-free survival is very, very poor. Now, this is a study I really like to help inform the debate or the discussion around lymph node dissection. And the reason I like it is because it shows us, well, where are the landing zones of bladder cancer lymph nodes? And what you'll find is that the vast majority of bladder cancer positive lymph nodes are in what we would consider the extended lymph node area. So and what I mean by that is the super extended does have positive lymph nodes, but the vast majority are in the extended lymph node packet. And this helped inform actually, one more discussion point around this is of the percentage, another way to say this is if you actually look at that super extended area, the percentage of patients undergoing a cystectomy with a lymph node that have lymph node metastases, around 6% will be above the aortic bifurcation. Around 25% will be above the iliac bifurcation. And then if you look at the anatomic distribution of patients who only had one positive lymph node, and I think this is an important concept because this is, okay, well, if they have one positive lymph node, where's it gonna be? This speaks to the idea of skip lesions. Basically, it's not gonna be anywhere near the bladder, but they'll have one positive lymph node in the retroperitoneum. Well, if you look at the data, 0% of patients had a level 3 skip met. So only one positive lymph node above the aortic bifurcation, but 10% did have skip metastases in the area between the iliac bifurcation and aortic bifurcation. And so the group from USC and the group from Bern did a retrospective study comparing and once again, this gets a little bit confusing with the nomenclature, but essentially a lymph node dissection that included everything, so presacral up to the IMA and everything in between, versus essentially the external iliac, internal iliac, and then several centimeters above the iliac bifurcation, but not yet to the aorta, and essentially found no difference in recurrence-free survival and overall survival between those two strategies. Problems with the retrospective data is that imaging may not have been as sensitive. So a lot of these patients were probably undergoing lymph node dissections, undergoing cystectomies who had notably positive lymph nodes on imaging that we would today not take for cystectomy. Neoadjuvant therapy was not as widespread. And there were non-standardized approaches to what to do with the patients who had positive lymph nodes. Nowadays, vast majority of those patients would go on to adjuvant therapy. So the EAU guidelines say about this, in conclusion, extended lymph node dissection might have a therapeutic benefit compared to less extensive lymph node dissection, but due to bias, no firm conclusions can be made. So this was the justification for writing a trial around this. This is the LEA trial. I never know how to pronounce it, out of Europe, that was recently published last year, that was comparing extended versus limited. This is very confusing. Limited in their eyes is really what we would consider standard, but basically extended versus standard lymph node dissection in bladder cancer patients undergoing a radical cystectomy. And as I just said, basically their version of standard is this area would be 5, 9, and 13, but does not include 10, which are the deep obturator nerves, and similarly on the other side. Whereas extended includes all of those things. And 400 patients were randomized to each arm, and I'm moving through things pretty quickly because I want to make sure I leave time to talk about bladder preservation as well. And what you'll note from this trial is that oddly enough, the number of patients with node positive disease was more 27 to 28% in the limited arm compared to 22% in the extended arm, which is a little bit confusing and difficult to interpret. And the other thing that should be noted about this trial is they included patients with non-muscle invasive bladder cancer. So they did not find a difference in well, let's just move on to that. They did not identify a difference in survival outcomes between the extended and the limited lymph node dissection, but they were likely underpowered to do so because they were not fully focused on the muscle invasive group. So this is the main criticism of the study, is that they found no difference, but there were some serious issues in how the study was powered. This, though, is also interesting. It did not show huge differences in major complication rates between an extended and limited lymph node dissection. The one difference that it did show is at 90 days, significantly more lymphoceles required drainage, which makes sense. But that was the only significant difference in complications. So this trial, around the same time that this trial kind of was getting off the ground and getting done, SWOG 1011 also was being planned, and this is a trial here in the United States that is randomizing standard, that is only relegated towards muscle invasive patients. Neoadjuvant chemotherapy is allowed, and it's randomizing patients towards standard lymph node dissection versus an extended lymph node dissection. And the way it's a little bit different from the European trial is, number one, its eligibility, which I discussed. And there's some minor, what I would consider minor differences in the sort of control arm. Basically, the European trial did not include the deep obturator lymph nodes. And, but this is a big difference, is that neoadjuvant chemotherapy is allowed in 1011, and more than half of the patients got it. So that's more of a real world sample for us. And we'll await the outcome, the reporting of this, which hopefully should be fairly soon. So new diagnostics may change the role of lymph node dissection altogether. At the same time we're discussing this, we have circulating tumor cells and circulating tumor DNA that are coming online. We have enhanced imaging with MRI and molecular imaging, and we have genomics. And so all of this may show us the burden of disease, the burden of bladder cancer that we currently don't know. Once we learn that there's a high burden of circulating tumor DNA, it may impact how and what kind of lymph node dissections we do. But clearly the take-home messages are that historic and retrospective series show that pelvic lymph node dissection is curative in a subset of patients. Mapping studies and non-randomized data demonstrate that there's a 5 to 10% skip lesion rate where nodes are only positive above the iliac bifurcation. And this probably drives the small but significant difference in survival, in my opinion. Retrospective series do show a modest but clinically meaningful improvement, and there are 2 randomized trials that have been performed, one of which, the German trial, which is reported out and showed no differences, but it's empowering issues, and SWOG 1011, which hopefully we'll find out about soon. Okay, let's use the remainder of our time to discuss the principles of bladder preservation, which is in the guidelines. So for patients with newly diagnosed non-metastatic muscle-invasive bladder cancer who desire to retain their bladder, and for those with significant comorbidities for whom radical cystectomy is not a treatment option, clinicians should offer bladder-preserving therapy when clinically appropriate. And this is in our guidelines. And there's been multiple studies showing that this does not actually happen, that a lot of urologists who, quite frankly, do not discuss bladder preservation in the run-of-the-mill muscle-invasive bladder cancer patient, but we should be discussing it. Additionally, when bladder preservation is offered through trimodal therapy, radiation sensitizing chemo should include cisplatin or 5-FU and mitomycin. And in patients who have residual recurrent muscle-invasive disease, a radical cystectomy and lymph node dissection should be offered. So what is bladder preservation? So this is my definition. Bladder preservation is a strategy for the treatment of bladder cancer with curative intent, whereby the bladder remains as a functional organ in the body. So when you put it like that, it actually encompasses a broad range of treatment. And I like this definition also because the urologist remains in the driver's seat with this definition. We are the experts of the bladder. If the bladder is remaining in the body as a functional organ, we are the captains of that ship. So when we discuss trimodal therapy, all patients who are considering trimodal therapy, chemoradiation, should undergo a maximal or a radical, however you want to call it, TURBT, where you're resecting down to fat, and we are absolutely sure that there is not going to be residual cancer, if at all possible, and I'll show why in a second. And that's basically because when you actually, I'll go back in a second, but when you actually look at the difference between a TURBT where there's visibly complete resections versus a TURBT where there's not visibly complete resection, this drives the CR rate after chemoradiation. So in the MGH series, the overall survival is, the CR rate 79% in the complete resection group versus 57% in the residual tumor group, and the survival outcomes kind of go along with that. So what are the considerations that what do we take into account when we consider trimodal therapy? I would say that this is changing, but still for the purposes of education, patients with hydronephrosis who are medically unable to tolerate chemotherapy, have diffuse CIS, and prostate stromal invasions are not going to be great candidates for trimodal therapy and are going to have a high rate of recurrence, needing a salvage cystectomy. But everyone else, to one degree or another, should be considered. And even there's some thought now that the hydronephrosis and the CIS is more of an art than a science, but that can be reserved for our discussion. So we have 8 minutes. I had a couple cases, but I want to leave time for questions. So I'm going to just spend, I'm going to actually jump ahead and just tell you that partial cystectomy should be considered in about 1 in 20 patients, in my opinion, are decent candidates for partial cystectomy. And that's basically a solitary lesion in an area of a bladder where complete margins can be easily obtained. So i.e. a diverticula or the bladder dome. And that's the exception rather than the rule in my practice. And I will just work through this and just say that I'm purposely not talking to you about urinary diversion because you're going to get that from Dr. Bachner. And let's just pause for a moment and talk about what I haven't talked about, which is any biology, which is amazing because that's very fun to talk about with bladder cancer, especially in 2020 when we have so much going on. This is data from the TCGA, and essentially what it is showing is that we have molecular classifications, but that these molecular classifications may be, and we will need trials to prove this out, but may allow us to have a sort of molecular staging system where we treat patients based on their molecular classification, and they get, some patients get chemotherapy, some patients get targeted therapies, some patients get anti-PD-L1 therapy, and some patients go on straight to cystectomy. So this may be a glimpse into the future, but this will need to be proven in trials before it's discussed as a principle in our guidelines. Thank you. And I just want to highlight that, in my opinion, these are, I may have left a few out, but for those of you who are viewing this as this is what I need to know for a test, or I'm not ever going to be, doing bladder cancer, whatever. These are still the studies to commit to memory and to understand for the, when you're in your rural country urology practice and you get a bladder cancer patient. All right, thank you. I'm going to stop there. I'm sorry I didn't have time to go over the cases because they're kind of fun, but I want to leave time for questions.
Thank you, Dr. Cates. That was a great, focus on muscle invasive, which we haven't had. We do have a good number of questions, so I'll just get started. In regards to prehabilitation, what is your protocol, and do you think it works?
Yeah, so our protocol is essentially that we have the patients meet with our stoma nurse and nurse practitioner preoperatively. We do a chlorhexidine scrub to the skin. We do Gatorade intake before, no mechanical bowel prep, and we're trying to have a actual physical therapy program put in place. That's something that we're working on right now. In all honesty, I think that we could do more in terms of actual physical therapy related prep for the operating room. I think that what we're doing with the bowels is pretty good, and in terms of avoiding wound infections is pretty good, but actual fitness, especially in our older, more frail patients, I think we can do a better job with.
And you mentioned, in regards to the circulating tumor cells, circulating tumor DNA, is there any evidence to suggest that a very maximal TURBT or re-TURBT can increase your risk of not only METs, but increasing that amount of circulating cell or tumor cell or DNA?
Yeah, that's a very good question. I think we don't know the answer. It's a very difficult question to study because if you're doing a maximal TURBT, then you're doing it because you're concerned about residual muscle invasive cancer, which is going to conflate any study you try to do around seeding.
Right. Along the same lines with regards to kind of the molecular classifications, any molecular or genomic information that contraindicates neoadjuvant chemo use?
Yeah, so not right now. I think what ideally is going to get done in the next couple years is we're going to have biomarkers potentially off of tumor blocks, but also potentially off of circulating DNA that direct towards chemotherapy versus cystectomy versus potentially immunotherapy. I think right now it hasn't fully gotten sorted out, and certainly not based on the typical molecular classification, basal luminal, luminal infiltrated kind of nomenclature that we currently use. No.
Okay. The next question is, what is the role of adjuvant therapy?
I'm trying to turn off this phone. Yeah, so I wanted to spend some time talking about adjuvant therapy. So adjuvant therapy is, there's some very good data to support adjuvant therapy, which is why it's in the guidelines. Primarily, most of that data is out of Europe. But I offer adjuvant therapy based on the guidelines and based on the data to every patient with that can tolerate it, with T3, T4, or N positive, node positive disease. So I think there is data to support adjuvant chemo. There is a randomized trial that is currently being done, the Ambassador study, which is randomizing patients to checkpoint inhibition versus observation if they are not a candidate for chemotherapy, or if they got neoadjuvant chemotherapy and they still have persistent muscle invasive or node positive disease. So that'll be really interesting too, because you want to give those patients something. The patients who have neoadjuvant chemo, who have persistent disease on their cystectomy, is a really bad prognosis a lot of times. And you want to be able to offer them something, but it needs to be proven. So that's why that study is going to be really informative.
Sure. And just kind of jumping back to the lymph node dissections, someone was asking just regarding the complication rates between the standard and the regular limited, and does it increase op time significantly?
I think that so once again, this is getting into nomenclature a lot, but maybe with the super, I do not perform a super extended. But in terms of just an extended versus standard, it does increase operative time, but on the order of 20 minutes or, in that neighborhood, not a lot. I think what it does do though, is it just creates more lymphocyles. I mean, I think that, that can't be argued. Whether there's more significant differences, I think, the European trial didn't show that. We'll have to see what 1011 shows.
Sure. And then someone asked specifically, what lymph node dissection template do you perform for clinical N0 disease?
That sounds like a McKiernan question. Who asked that?
Not Dr. McKiernan.
Okay. Yeah, so I would say that when feasible, I do an extended lymph node dissection and in muscle invasive disease. So I'm not confident, based on data out of Hopkins, I'm not confident in my ability to detect CT0. So I don't change my management decisions at this point based on the clinical staging after chemotherapy.
Gotcha. Well, Dr. Cates, thank you so much. So many people enjoyed this talk. If you missed